Good morning, everybody. My name is morning. I'm Dr. Neil Khan. I'm one of the cardiologists at St. Luke's Hospital, and I'm happy to be here this morning to discuss strokes and stroke awareness with the community. If you have any questions while I present or after, please feel free. I guess we could do a classroom style where you raise your hand and I can call on you. But I'm going to talk about the basics of stroke, basically what it is, and some of the things that we can do to help prevent strokes. And obviously, if you've had a stroke, big or small, some of the things that are done to help you in the future and prevent it from happening again. So, happy to be here. All right, so basically, what is a stroke? The short of it is that a stroke is a disease that affects someone, and usually they have a motor or sensory deficit, and it's usually caused because lack of blood flow to the brain. Now, this could be because of a blockage in an artery that goes to the brain, or it could be because a blood vessel in the brain bursts, and as a result, that blood is not getting to the brain either. So I'll talk about both. The important thing to note is that, like everything else in the body, everything that is living in this world needs oxygen in order to survive. And the brain is almost a separate person of its own. If it does not have oxygen, parts of it will start to die, and as parts of the brain start to die, you start to feel some of the symptoms. So just some of the facts, how prevalent is strokes? Well, I'm talking about high blood pressure because if you were to ask me what is the single leading cause of strokes, at least in America, it's high blood pressure. Either because it causes a blockage that will prevent blood flow to the brain, or because it causes a burst blood vessel in the brain. High blood pressure is the key factor in all this. 1 in 3 adults have high blood pressure. We label an adult as someone over the age of 40. 21% of people do not even know that they have high blood pressure. Even more than that, probably close to 50% of people, even some of which who know they have high blood pressure, do not have it controlled with medication or because they're not taking medication. In the United States, about 76 million people aged 20 and older, actually this is a worldwide stat, have high blood pressure. In terms of stroke, how frequently does it happen? About every 40 seconds someone has a stroke. Some people estimate it's even more than that because of undiagnosed strokes. And every 4 minutes someone dies of a stroke, unfortunately. A stroke is the cause of death in one in every 6 deaths. So approximately this year, this was actually data from last year, approximately 795,000 people will have a stroke this year. And what's the point of all this? It's really prevalent. It happens a lot of people suffer from it. And some of you may have even heard friends or yourself, these are not even counting asymptomatic strokes, meaning there's sometimes when you go to your doctor and they're concerned about something, they do a CAT scan of your brain and they tell you had an old stroke. This is not even counting those. Sometimes people can have relatively asymptomatic strokes, and this, obviously those, like I said, are not even counted in this. If we're talking about what disability and what cost it is, it's a huge cost, really because of hospital time and future medical care. Stroke-related costs in the United States came out to about $46 billion. So, there's not as much money invested in stroke prevention as there should be in community outreach and education of patients, which is what we're trying to do here. So like I said at the beginning, what causes a stroke? Basically, it's a clot that's obstructing the flow to the brain. This is called an ischemic stroke. There are 2 kinds of strokes, like I said, ischemic and hemorrhagic. Ischemic stroke basically means something got in the way, one of the blood vessels that go to the brain, something got in the way of the blood flowing there. That can be because of a plaque that built up in that artery, and the most common arteries are the internal carotid arteries, which are in your neck, which your doctors may have checked. The other cause is sometimes people have a blood clot somewhere in their body. Usually it gets to the heart, and if you were to look at how the heart works, the first stop is the brain. So if you have a blood clot in the brain, there's a very high chance that that blood clot will go to the if you have a blood clot in the heart, there's a very high chance that blood clot will go to the brain before it goes to any other organs. That is the basis behind atrial fibrillation, and we'll talk about that a little bit later for those of you who have heard of it. Which one is more common, ischemic strokes or hemorrhagic strokes? Like I said before, hemorrhagic strokes is basically a vessel ruptures in the brain. Some of this is because, unfortunately, people are genetically born with aneurysms or little balloon outpoppings of arteries in their brain, and it bursts. Honestly, some of that is bad luck with genetics, but that's relatively rare. Most causes of hemorrhagic strokes where people bleed is because of uncontrolled high blood pressure. If you increase the blood pressure enough, these small blood vessels that are in the brain will rupture, and it can cause bleeding. And that bleeding puts a lot of pressure on the brain, and as a result, you have a lot of effects, and it's more likely to be deadly. Which one is more common? 80% of all strokes are ischemic, so most strokes are caused by blockages that prevent blood flow to the brain. So what are the effects of stroke? And we'll go through a FAST algorithm acronym, which I think is pretty useful. But basically, if blood is not getting to the brain, you have certain sections of your brain that control certain motor functions. For example, the parietal lobe, which is the side part of the brain, which is where the major arteries feed. If something happens there, you're very likely to have major motor deficits, weakness, you can't move an arm. And also sensory deficits, whereas if something happens in the back of the brain in a part called the cerebellum, some people just feel extreme dizziness, and they can't walk and they feel unsteady. So it really depends on where the blockage is, and the brain obviously controls a lot of motor functions and balance and thoughts, and so you can have a variety of symptoms. So the important thing about strokes that are acute, meaning they just happen, is that they happen very quickly, and the symptoms also happen very quickly. And we can't emphasize this enough, and it's really a major reason of why there is community outreach about this, is because, as with heart attacks, but arguably maybe even more important, there is such an importance on the time that it takes you to get medical attention with strokes. If you wait too long, the deficits will be permanent and very difficult to overcome. The sooner you get there, people get to the hospital relatively quickly, and this goes, I'm a cardiologist, so this goes for heart attacks also with chest pain, but the people who get complete recovery are the people who come to the hospital right away. Those are the people who get the complete recovery. So what are some of the symptoms? You can have numbness or weakness, especially if it's on one side of the body. That should make you very suspicious, because each side of the brain controls the opposite side of the body, except for the face, which is the same side, but that's a little complicated. But if there's confusion, trouble speaking, obviously as we get older, a lot of things can cause this. If you have a fever, you can have similar symptoms also. But if there is trouble speaking, that should set a signal off. If you see it with a loved one, or even if you notice it with yourself, you should bring it to someone's attention any way that you can. If you have trouble seeing in one or both eyes and your vision is completely lost, that's very suspicious for potentially a blood clot that went to your eye, which is also a type of stroke. If you have trouble walking, dizziness, loss of balance, or severe headache, and you don't know what the cause is, these should also raise your concern. Obviously, the hallmark of this is it's generally not a gradual pain. It's not like, okay, a couple of days ago it was mild, now it's moderate, and now it's getting severe. Obviously something's wrong there, but generally with a stroke, it's 0 to 60 miles per hour right away. You feel symptoms very significantly right away. So I was talking about this FAST algorithm, and what are some of the things that people can do for you or you can do for other people who you're suspecting a stroke. They've made this FAST algorithm which sort of outlines what are some of the stuff you can do. So F stands for face. So basically, you ask the person to smile. And so if it's someone you know well, you'll recognize any changes very quickly, or they'll recognize it in themselves. Not all strokes are people completely out of it. Usually you're not. You can notice the differences yourself. So what we say is to try to smile. You have to use the muscles in order to see that they're not working. So you try to smile. If you notice that there's a difference from one side of your face to the other and that your smile is drooping to one side, it's very suspicious for a stroke. A stands for arms, and it's raising both arms. Now, obviously, if you cannot raise one arm, something's wrong. You know, if you're usually able to raise your arm, that's definitely something's wrong, and you probably don't even need to do this algorithm because you know something's seriously wrong. But for more subtle changes, which can happen in the very early part of a stroke, what you'll notice is that if you raise both arms above your head, one side, the side that's affected, which is the opposite side of the brain which is affected, you'll start to drift in space. The other arm will stay totally straight. And so that's a loss of motor control over the arm in the very early stages. Obviously, in the late stage, you just won't be able to move it. But in the beginning, it's you can raise it up initially and then it just starts to drift off to the side. S stands for speech. Ask the person to repeat a simple sentence. Obviously, asking them to talk, it can be a little confusing because, it could be the phrase, they could just say one word, but if you ask them to say a specific sentence, then you'll be able to tell if there's, a significant change that happened. And then T is probably the most important, like I said before, which is time. The faster you get medical attention, the quicker it'll be. My general opinion on this is that if you're suspecting a stroke, and even if you're having significant chest pain, don't go to urgent cares. Don't go to urgent care. Because it can, in some cases, just delay things. They're not going to be able to give you the treatment that you need there. They're going to end up transferring you. They're good at transferring you relatively quickly, but you are going to get transferred to a hospital. So I would say go to a hospital. In this area, obviously, St. Luke's is one of the places where they treat acute strokes and obviously acute heart attacks. We put stents and open up arteries right away. So if you're suspecting a stroke or you're having significant chest pain, then go to the nearest hospital. Okay, and this is obviously if you have someone to drive you. Obviously, the best thing to do is if someone calls 911. What's the reason for that? Is because if your deficits or symptoms are severe, and God forbid, you quickly go in the wrong direction, EMS can give you some of the care while you're being transported to the hospital that your family member probably does not even know to do. Trained paramedics can make a very big difference in the short term. All right, so what do I mean by get immediate help? I mean, obviously, not everyone feels symptoms and right away is like, let me go to the hospital immediately. Obviously, things take time to find somebody to take you and a bunch of issues that I understand exist. But we give a time of 4.5 hours, meaning from the onset of your symptoms when you first notice it to when you should be speaking to a doctor in an emergency room is 4.5 hours. And what's the reason for this? That is the amount of time that we are allowed to give a medication called TPA. It's a clot buster. So basically, if you have a clot in the heart, in one of the blood vessels that go to the brain, we have a very powerful medication that can burst that clot and can allow blood back there. I mean, I've seen people who cannot speak, cannot move one complete side of their body, and within 30 minutes of getting TPA, they're back to normal. So it's a high-risk medication because it can burst clots other places also, but the benefits far outweigh the risks of it. We cannot give it if it's more than 4.5 hours. Even if it's approaching that 4.5 hour time, we're very restrictive because the clot may be too solid for this medication to work at that point. You want to get it when the clot is soft. You should come to get medical attention either way, but I'm just talking about this medication. And TPA is the only FDA-approved medication for the treatment of stroke. So we give that time of 4.5 hours. The truth of the matter is, to get the best results, you need to come within 3 hours, meaning you need to be in the hospital within 3 hours. It's not really mentioned here, and honestly, we don't do this treatment here, but we transfer to interventional stroke centers for people who may have a bleeding issue or have a contraindication to giving this clot busting medication, TPA. We can actually send, like how we do with the heart, which we do at St. Luke's, we send catheters up and we open up the blockage. For the heart, we do that here. Unfortunately, for the brain, we don't yet do that in Orange County or even in Rockland County. The closest place is Westchester Medical Center. If someone cannot get TPA, often we transfer them to Westchester to potentially get that procedure if they cannot get TPA. But the bottom line is, the sooner you come, the sooner you can get one of these treatments. Just a word about TIA. You may have heard this term before. It's an acronym also that stands for transient ischemic attack. You can basically think of it as a warning stroke, and it really is a warning stroke. It's a deficit where you have some of those same symptoms that I described before, but they resolve totally. And we're saying resolve within 24 hours. Some stroke symptoms can resolve very quickly too after we give treatment. That's not a TIA. A TIA is when it resolves without us doing anything. And the reason for it is probably because it was a small clot that went up and the body broke it up itself, because the body does break up clots naturally. So the reason we're so strict about TIAs is when someone has a TIA, we start to look at things. We look at the carotid arteries in the neck to see, are there blockages there that are showering off little pieces to the brain? Is there a blood clot in the heart? Is there something wrong with the heart that's causing this stroke? So TIAs often, when someone comes in with it, their deficits resolve, and then we find basically ticking time bombs that could cause a more major stroke in the future. Very often, within 2 weeks after someone has a TIA, they have a major stroke if they don't get medical attention. So it really is a warning thing. Just like, I can tell you the number of people who I treat for heart attack, who came in with a major heart attack, who tell me for 2 weeks or 1 month they've been having intermittent chest pain. Those are warning signs before the artery totally closes, and you should, especially if you have risk factors and you're older, you should really take those warning signs very seriously. Okay, like I said, TIA should be recognized very quickly. You should seek medical attention. Even if the symptoms resolve, you should seek medical attention. Okay, so like I said, seek medical attention. Often, people even come to our outpatient offices and discuss some of the symptoms they have, and we can do a workup there. If the symptoms were pretty severe, you should seek attention in a hospital. So what are some of the tests that your doctor may do in and out of the hospital? A CT scan or an MRI are very specific tools where we can actually look at the brain and see whether there's been a stroke. A CT scan is very good at picking up older strokes. An MRI is even more sensitive. It'll pick up old strokes and it'll pick up a brand new stroke. Sometimes the CT scan does not show a new stroke for at least 48 to 72 hours. So you may come in with a stroke, they do a CT scan, they don't see anything. We would still treat you for a stroke if you had symptoms. And often what happens is we don't repeat the CT scan. On day 2 or 3, we do the MRI, and then we see that the stroke actually did happen. Some of the other things, carotid ultrasound, that's a simple procedure that we often even do in the office, which is just an ultrasound of your neck arteries. This is where the majority of plaque builds up that goes to the brain. And if you have risk factors, it's probably a good idea to have this checked to make sure you don't have a significant blockage that's brewing in one of your neck arteries called the carotid arteries. And cerebral angiography is basically where they actually look at the arteries. So what are some of the risk factors of stroke, and when should you be more concerned? Obviously you should be concerned if you have any symptoms, but what about before you have symptoms, about your risk? The chance of having a stroke actually doubles every decade after the age of 55. And that's just because, unfortunately, plaque builds up over years. And the longer we live, the longer plaque builds up, and the more severe the disease can be. A family history of stroke or heart attack should be taken very seriously, especially if that family member did not have any really bad habits like smoking or things like that, because probably there's a genetic risk underlying, like cholesterol or something like that. If you have a first-degree relative that has had a stroke, your stroke risk in your lifetime is probably more than 50%. Okay, so what are some of the non-modifiable risk factors? What are some of the things we can't change? Obviously, you can't change your race. African Americans have a much higher risk of death from a stroke. That could be a variety of issues: getting medical attention, the scarcity of hospitals in certain regions. But really, a major cause of it is a higher incidence of high blood pressure and diabetes and obesity. High blood pressure and diabetes are two of the biggest modifiable risk factors, meaning something we can do something about, that cause strokes and heart attacks. And if you have high blood pressure and diabetes, it is in your best interest to make sure it is treated and controlled as tightly as possible. If you have diabetes and high blood pressure, and with medication or diet, you have it totally controlled to the normal range, your risk is as if you didn't have the disease at all. So controlling this is very important. Obviously, gender plays a role. Stroke is more common in men. Men have more premature buildup of vascular disease. It is probably underdiagnosed in women because, just generally speaking, women have more atypical symptoms when it comes to heart attack or stroke. Stroke, much less so. Heart attack, often they have GI symptoms like reflux and indigestion. For stroke, it's more similar, but often, for whatever reason, it's underdiagnosed in women. What are some non-modifiable risk factors? Obviously, like I told you, if you've had a TIA, you're almost 10 times more likely to have a stroke in a short period of time than people who have not had TIAs. If you've had a heart attack, you're also at a very high risk of stroke, because after a heart attack, the heart can become weak and blood clots can form in the heart as a result. I cannot stress enough about high blood pressure. High blood pressure is the major cause of stroke. And sometimes it's not even because it causes a blockage. Sometimes it's because it causes closure of little small arteries in the middle of the brain that cause major symptoms. And it's just because over time the high blood pressure has damaged these arteries. Another risk factor that's modifiable that we can control: smoking. Smoking is, aside from often the genetic causes of stroke and heart attack, like high blood pressure and diabetes, cigarette smoking is obviously totally a behavioral thing, and it causes a significant problem for multiple reasons. Your blood clots quicker when you smoke. Smoking, just the carbon monoxide in cigarette smoke and the nicotine, causes damage to the lining of all the arteries in your body. So classically, I know that, let's say I'm doing an angiogram of the heart on someone who smokes, we always know we're going to see disease in the heart arteries. It's going to be there because it causes a pretty diffuse damage to the lining of the arteries, and then plaque builds on top of that. So smoking is a major risk factor. Diabetes is another one. Actually, interestingly, often when we look at the arteries of people who smoke and have diabetes, they look very similar. They both damage the lining of blood vessels, And whenever a blood vessel's lining is damaged, debris form on top of it. And by debris, I mean cholesterol. So if you have cholesterol floating around in your blood, it's going to stick to the artery if there's damage done to it.
Yes.
One of the other things that you can look at is peripheral artery disease. You know, some of you have maybe been tested for blockages in your legs, or maybe have had a carotid ultrasound. If you pick up on one of these tests that you have vascular disease, or your doctor tells you you have plaque, there's a high chance that that plaque is present everywhere. It usually doesn't just go to one place in the body. It usually goes everywhere. So what I tell patients is that if we find out they have significant plaque, let's say in their leg, or they did a CT scan of their stomach because of stomach pain and you see that they have plaque in their aorta in their stomach, I tell them that this is a warning sign that they probably have plaque other places and we should be aggressive about their risk factors. So any peripheral artery disease means that you have fatty buildup in your arteries probably everywhere. Like I said, carotid or other artery disease, this is just a picture. Okay. There's a pointer on there.
Yes, that's that button. Yeah.
Well, that's good. So this is just an example of plaque. You see probably there was damage in the lining here, and as a result, little fatty molecules, cholesterol, stuck to this artery, and it's stuck on both sides, and then as a result, the only blood flow that can get through is this small sliver. So you can start to get symptoms at this point. When someone comes in with a stroke, what happens is this totally closes. Now, why would this totally close? It's because it's so narrow, and this goes for the heart too. This is actually an example of the heart, but this goes for the brain also. That the flow is so slow in this blockage because it's so narrow that little platelets and blood clotting factors in your blood stick to that, and a blood clot forms here and it totally blocks the blood flow. Which is why we have some people on aspirin who have plaque disease, because the aspirin will help prevent the buildup of a clot here and prevent an actual stroke from happening. But the important thing to recognize is often people can start to get symptoms when this is going on. When there's still blood flow, you didn't yet have a heart attack or a stroke, there's still blood flow, but it's narrowing, so it's giving you warning signs. All right, other risk factors. This is a major one, and many of you have probably heard of this with commercials or yourself or family members, but atrial fibrillation is a very significant cause of stroke, and I say that for two reasons. Number one, atrial fibrillation often is a disease of age. As we get older than 70 years of old, many people have atrial fibrillation. It's basically because of a scarring in the top part of the heart, and then your regular heart rhythm is overtaken by sort of a disorganized heart rhythm. The top part of the heart no longer pumps, it quivers, it fibrillates. That's what fibrillate means. It sort of quivers and doesn't really pump. As a result, blood that's there can swirl and clot, and then that clot, like I said, the first stop is the brain that can cause a stroke. So people who have diagnosed atrial fibrillation who are over the age of 65 should be on blood thinners. You may have heard about some of them, warfarin, Coumadin. It's a little older, but Eliquis, Xarelto. These are all medications that thin your blood if you have atrial fibrillation. If you do not thin your blood in atrial fibrillation, you have a very high risk of a stroke. The reason we stress this is because the strokes that happen with atrial fibrillation tend to be large strokes, because the blood clot that forms in the heart is a big clot. So it tends to be even bigger stroke than what people naturally get when they develop a blockage in their carotid arteries. Atrial fibrillation should be taken very seriously. Coronary artery disease and heart failure is another cause of stroke. Because the heart is weak, same reasoning, a blood clot can form in the heart because the heart's not pumping the blood out as quickly. And if any blood sits anywhere, it clots, and that's what blood does. So other risk factors that you can modify, cholesterol. Cholesterol is a huge thing. Anybody who has evidence of any plaque should have aggressive treatment of their cholesterol. You should look at your numbers. Your doctor will look at your numbers. People really benefit from decreasing their LDL, which is the bad cholesterol, when they have plaque buildup. Really, anybody over the age of 65 should know what their cholesterol levels are because people do better if their cholesterol is lower. Diets that are very high in saturated fats, canned foods, cold cuts, and high in salt can increase blood pressure and cause an increase in LDL and cause the plaque buildup. Physical activity, and I can't stress this enough because physical activity and exercise helps everything. It helps blood pressure, it helps cholesterol, it helps diabetes. And exercise does not have to be, running a marathon, running a half marathon. It can just be walking 20, 25 minutes 5 times a week. But walking at a pace that's a little faster than a stroll, so that you're getting your heart rate up, you're breathing a little harder than what's normal for you. And this just helps the blood flow more quickly through the body, allows blood to flow everywhere in the body and keeps everything moving. It's without a doubt that a regular exercise regimen has been shown to really decrease your risk of high blood pressure, cholesterol, diabetes, and obviously, as a result, then stroke and heart attack. One of the smaller risks is alcohol abuse, but it's still a risk for everything. Obviously, excess alcohol is terrible for many reasons, but one of the major reasons is that it causes a lot of oxidants in your blood to cause damage everywhere. So, if we look at the brain of people who are chronic heavy alcohol users, often it's much smaller than what it should be. It atrophies or dies over time. And so as a result, people get a lot more symptoms, and when they do get a stroke, they'll be a lot more symptomatic from it because they're not starting at zero, they're already starting with an issue. So what can we do to prevent it? We talked about the modifiable risk factors. If you have high blood pressure, diabetes, obviously if you smoke, these are all things that need to be targeted to make sure that your risk of stroke and heart attack are reduced. I personally feel, and I think it's gone away in primary care, but anyone over the age of 60 to 65 should have an EKG at least every year to make sure they're not in atrial fibrillation, because like I said, that can be a major cause of stroke. Obviously, if you have any symptoms like palpitations or chest pain, an EKG is warranted. But even if you're feeling good, doctors should do an EKG once a year as we get older to make sure that none of these other issues are going on. But what are some of the things you can do? Aspirin, these are all antiplatelets, meaning they work against platelets to prevent that blood clot from forming that I talked about before. Aspirin is the most common, but if someone has had a stroke, often we use these other ones called clopidogrel and Agramox. They're stronger. They work against platelets and they prevent blood clots. Generally, I don't recommend people being on, clopidogrel or Agramox unless they've had a stroke to prevent it. Aspirin is much more controversial, and some of you guys have probably heard about this. There's a bit of an aspirin controversy. We used to put everyone on aspirin once they get over a certain age. What we started to see is that people fall and people hit their head, especially as we get older, and people injure themselves, and then you can have a life-threatening bleed from that in and of itself. So people who don't have proven vascular disease generally should not be on aspirin. Unless, obviously, if you've had a previous stroke, you have proven vascular disease. But often what I will do, or many people will do, is do an assessment of once you get to a certain age of whether you have plaque buildup. There's something called a calcium score that your doctor can order to see how much calcium is in your arteries. Calcium forms the outer layer of plaque. So the more calcium you have, the more plaque you have. Or someone will do a simple test like a carotid ultrasound and see how much plaque you have, and that will determine whether we think you should be on aspirin or not. Obviously, younger people, some people use it as soon as they turn 40, they used to take aspirin. Probably not a good idea. A lot of people don't have anything, if they take care of themselves, they don't have any significant plaque at 40. And, God forbid they're in a car accident, that aspirin could be costly to them. I mentioned Coumadin and NOACs. NOACs stand for novel anticoagulants, like Eliquis and Xarelto, which you may have seen commercials for. These are blood thinners that are a must if you have atrial fibrillation. Because, like I said, atrial fibrillation causes strokes. Statins, I think are great medications. Statins reduce your cholesterol and stabilize plaque. I can tell you a lot of heart doctors take statins whether they need it or not because it's been proven to reduce your risk of heart attack or stroke. If you have risk factors and your LDL, which is the bad cholesterol, is high, often your doctor will recommend a statin to just reduce your risk a little bit. This is a little bit for our younger patients. A PFO is a patent foramina valley, which is basically a hole in the heart that everyone is born with, but in about 78% of people, it closes on its own. And so in 22% of people, it does not close. Is the math right? I think the math is right. So in 22% of people, it does not close. As a result, little blood clots that form in your veins, which happen all the time, can cross over that little hole and cause a stroke. So we call that a cryptogenic stroke because we often don't know what caused it. These are usually younger patients who don't have risk factors who come in with a stroke. It's very high chance it's because of this hole in the heart, and we do a sonogram of the heart to see if they have that, and in 2022 we can fix it without a surgery with a one-day procedure where we plug up that hole. So, like I said, this is typically of younger patients. Generally speaking, once you're over the age of 60, your risk of having a stroke due to a PFO is smaller because it's probably other things that are causing your stroke. So just a word about Montefiore. It's a designated stroke center. Like I said, for stroke-related symptoms, I do not think that urgent cares are the best just because they cannot give the type of medication that you may need at the urgent cares. They will have to transfer you. Going to a hospital like St. Luke's where they can deliver timely care is extremely important. So, summary. All individuals should have their stroke risks assessed. What does that mean? You should have yearly blood work. If you're over the age of 65, you should probably have blood work every 6 months. If you have high blood pressure, diabetes, these should be regularly checked and make sure they're controlled. Risk factors, these diseases do not happen without risk factors being somewhat uncontrolled. If you control your risk factors, of course, if you don't have an aneurysm in the brain, like I said, that's a little bit of bad luck because often people can take care of themselves really well. If they have an aneurysm, it can rupture. But that's very rare. Most strokes and heart attacks are caused by risk factors that are being undertreated. All risk factors should be aggressively treated. Try to be active, have an exercise plan. Does not have to be very intensive, but it also allows you to have a better idea of what your symptoms are. Often the more sedentary we are, we don't realize little changes in our symptoms over time. It's when you force yourself to do things that you notice that something's a little different than what it was before. And people who have non-modifiable risk factors, meaning things that they have no control over, like AFib and things like that, it should be followed very carefully to make sure that their stroke risk is smaller. And like I said, remember that if there's a concern for a stroke, this FAST algorithm, just simply asking someone to smile, to say a sentence, or raise their arms can tell you very early in the process whether something is going on, and if it is, you should seek medical attention so that you can potentially get a very good outcome.